We present a case of suspected bupropion-induced hepatotoxicity. In our case, we have a 58-year-old male with muscle-invasive bladder cancer, hypertension, and type 2 diabetes. He presented with a month of scleral icterus and obstructive liver function tests noted on routine labs. His other symptoms include pruritus, dark urine, and some mild epigastric abdominal pain. On admission, his labs were notable for elevated transaminases with AST of 119 and ALT of 101, a total bilirubin of 10.3 with a direct bilirubin of 6, ALP of 862, and an INR of 1.3. His CT chest abdomen pelvis showed a known lung nodule and left hydronephrosis. An ultrasound and MR pancreas liver did not reveal any mass, biliary dilation, or hepatic steatosis. At this point, it was unclear what was causing this severe liver toxicity. His only home medications included a combination glipizide metformin for his diabetes and bupropion. Of note, the bupropion was started about 2 months before admission for depression. The patient's ANA-AMA, anti-smooth muscle, hepatitis B and C serologies were negative. Wilson's disease and alpha-1 antitrypsin deficiency were also ruled out. His bupropion was discontinued 2 days into admission. Interventional radiology completed a transjugular liver biopsy, which revealed marked cholestasis and ductular reaction in perisinusoidal and periportal fibrosis on trichrome stain. His total bilirubin shortly after discharge peaked at 11.3 with a direct bili of 7. He was started on steroids outpatient. 1 month after discharge, his total bilirubin was 1.9 with a direct bili of 1.3, and 3 months after discharge, his total bilirubin was normal at 0.8. Bupropion-induced liver toxicity is a potentially rare side effect that is not acknowledged in any randomized controlled trials. We in fact only found 9 reported cases of hepatotoxicity considered to be induced by bupropion. Table 1 shows these cases along with our patient case. Bupropion causes hepatotoxicity in between 0.1% and 1% of treated patients and presents with either a hepatocellular and/or cholestatic pattern of damage. The mechanism of damage is thought to be immune-mediated, with a short latency period of 1 to 6 weeks. Treatment with a high-dose prednisone taper was started in all cases after cessation of the bupropion. In our case, histologic findings were attributed to biliary outflow obstruction, the etiology of which is likely multifactorial, mechanical, or functional, including drug-induced. In conclusion, hepatotoxicity is a potentially rare but serious side effect of bupropion. Patients should be monitored carefully after bupropion initiation, and cessation should be considered in a case of jaundice and abnormal liver function tests with unknown etiology. Drug-induced liver injury is a diagnosis of exclusion. There also may be some utility in liver function testing and surveillance in patients started on bupropion, but this is an area that needs to be explored more.